Hello, and welcome to Healthcare Excellence Canada's webinar series on promising practices to enable aging in place. I'm Andrea Piche, and I'm pleased to be your host today. Please note that this session is being recorded. This is the second webinar in a three-part webinar series where each webinar features two promising practices in Canada. Through our Enabling Aging in Place collaborative, HEC has had the privilege of learning about so many great programs and initiatives to support aging in place. And we know that folks across the country are keen to learn what others are doing. Next slide. We're pleased to offer French simultaneous interpretation by Boost Events, a subsidiary of Boost Lingo, for this session. If you wish to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. If you need support at any time during this webinar, you can reach out to tech support using the chat feature. We invite you to share your questions and comments at any point using our chat box in either English or French, and we encourage all of you to respond to the comments and answer questions in the chat as you wish as we go along. We'll aim to connect as many of your questions as we can with our speakers during the Q&A session at the end of the webinar, but please recognize that we may not have enough time to answer every question. In our follow-up email, we'll include answers to all the questions that have been asked. This session is being recorded, and a link to the recording will be available next week for you to review or share with your colleagues who may have missed it. Next slide. Enabling aging in place is place-based work. Where we are matters. I'd like to start by acknowledging that we are meeting on land that has been inhabited by Indigenous peoples since the beginning. In particular, we acknowledge that we are broadcasting this webinar from Ottawa, which is the traditional and unceded territory of the Algonquin Nation. We recognize and deeply appreciate the historic connection to the lands where we work, live, and play, and the opportunity to gather here today. I invite you to say hello in the chat, and please share the name of the ancestral lands that you're joining from. Next slide. HEC is proud to be supporting work to enable aging in place. The work we're supporting, including the programs and initiatives featured in this webinar series, all align with the key principles to an aging in place that are shown on this slide. For more details about these principles and how we arrived at them, you can review the video from our first webinar in this series, which is available on our HEC's website, and we'll also post it in the chat. Additionally, these principles are described in each of our promising practices case studies, which are also available on our webpage and will be posted for you in the chat. Next slide. And so today, I am pleased to host representatives from two promising practices that exemplify the EAIP program principles in a beautiful way. From the NORC Innovation Centre at the University Health Network, we have Jen Recknagel and Melissa Chang. Jen combines expertise in human-centered design with a systems thinking approach to tackle challenges at the intersection of health and its social determinants. With a background in seamlessly integrating participatory and community-led solutions within the healthcare system, she currently leads an innovation program focused on reimagining support structures for older adults, emphasizing empowerment and ensuring timely access to care. Jen has assumed leadership in various initiatives dedicated to advancing naturally occurring retirement communities, or NORC programs, in Ontario, including spearheading the NORC Ambassadors Program and serving as a contributing author to the Ontario COVID-19 Science Advisory Table Brief, and outlining a vaccination strategy for high-density, high-risk NORCs buildings in Toronto. As a co-founder of The Local, a highly regarded magazine addressing urban health issues in Toronto, Jen has consistently demonstrated a proven track record of insightful contributions. Melissa works to bring ideas and people together to deliver new ways to approach health and well-being. She has over 15 years of healthcare leadership experience with a track record of successful projects that have benefited tens of thousands of individuals across Ontario. Her expertise in change management, implementation science, and digital health is currently focused on delivering new integrated models of care to benefit communities and populations most in need. She's established partnerships to support system-wide priorities spanning the continuum of care to scalable and sustainable solutions. She leads integrated care initiatives for the University Health Network Connected Care and is a board member at Unison Community Health Centre, focused on serving some of Toronto's priority neighborhoods. And from the Nav-CARE program, we have Gloria Pervine. Gloria is a researcher. She's deeply passionate about improving the lives of older adults living with declining health and their carers, whether in community or in long-term care settings. She holds a PhD in interdisciplinary studies from the University of British Columbia and is currently the project manager and knowledge translation lead for the Nav-CARE program. Welcome, all of you. At this time, I'd love to invite Melissa and Jen to come on camera. And we'll move to the next slide. And if it's okay with you both, well, first I'd just like to say hello and welcome.
Hi.
Hi, nice to
Hello.
see you. Are you ready? Can I turn the slides over to you?
Absolutely.
All right. Thanks
Thank
so
you.
much.
Hi, everyone. Thanks for spending some time with us today. Really thrilled to be able to share the work that we're doing. I'll introduce myself quickly. Melissa Chang. So Andrea did a great job. I'm the Senior Director for the NORC Innovation Centre, and I'm joined by my colleague, Jen Recknagel, who is our Director for Design and Innovation. So we've got a few minutes. I think we want to do our best to stay on time, Jen. So I'm going to move just to share. I think one of the things we were asked to share is how did we get to where we are? So I'll share a little bit about the background. For those of you that don't know, NORC stands for Naturally Occurring Retirement Communities. And they are not like a construct that anyone kind of approves. They're more of a geographical designation, looking at an area or building where older adults are naturally moving to. And our definition is looking at least 30% of a building or area is those 65 and older. So just so that I get that out of the way, it is a long acronym. Just to give a sense, we've been working on this work, the team here, for more than a decade, and really fortunate that Jen really led the charge in investigating a number of grassroots efforts early on around senior social living. And in that work that she did, really came across the concept of NORCs and the value of NORC programming, including looking at a lot of work in the United States, particularly visiting some of the pioneering work in New York. And so I think Jen also even had a chance to go there and learn from that area. And really starting from that learning is really earnestly exploring what are the possibilities and doing some work in the community, including really focusing on relational care and participatory decision-making and design. And so I think you'll hear a little bit more about our work moving forward, as that really is coming across to be some of the secret sauce. And today what we're going to focus on is really sharing with you what we've learned and what we've started around taking a really data-driven and evidence-informed approach to our work. There's many ways to support aging in place, and I hope what you'll find today is that we really looked at using data to identify some areas where we can make the biggest impact, but also knowing the strains on our health and care system, looking at where we can have efficiencies by leveraging that density of these buildings. And the impact of that. So you can go to the next slide. So we are based in Toronto. We are working with a number of partners and learning from other groups right across the country, and we hear weekly from those who are interested in learning about our work. But where we are starting in the first few years is really a focus on Toronto for a number of reasons. One is that based on our data, we are seeing quite a trend in the Statistics Canada data that shows that many older adults are moving to much more high urban neighborhoods, and also that there is a trend to move towards high-rise buildings. And so what you'll see, that similar trend is really happening right across Canada. And so as a proxy, if you look at Toronto, the data tells us right now it's 36% of older adults are now living in high-rise buildings. And if we go to the next slide, I think this will quickly just help to demonstrate more of the numbers. But our team has really been looking at mapping out where these buildings are. And so you'll see that as one example in Ontario, what that looks like across the population. So just to clarify, like, these are not retirement homes, nor have they been purpose built for older adults, but it is just naturally where individuals are moving to. And they can be a mix of, apartment buildings, condos, and co-ops. And we're really trying to learn in our first number of years what would be the best approach, what are the nuances between those different kinds of buildings and the different populations that we might be serving. Key to this is you'll notice there are actually more adults in Ontario living in NORC buildings than in long-term care and retirement homes combined. So we really took a look at this to see, how could we reimagine and look at the different ways that community building and delivery of health and social care services could be delivered. So we'll go to the next slide. Taking a look at that data, that is really the kind of the precedent and precipice to launch the NORC Innovation Centre, which you see our mission on the space there, and really what we're looking at is, what are some of the new ways where we can really work and be led by local leaders to identify new ways to age with dignity and in place. And so a lot of our work, you'll hear a lot today about our specific model and the programming. But we also are looking at our data, how does that influence policy? And quite a lot of research effort is being put in. In particular, we have a partnership with Women's College Hospital, their Women's Age Lab, to look at a multi-year research and evaluation study so that we can really determine, where do these models make the most sense? What kind of programming is most successful and achieves the biggest impact? Next slide. So just very quickly, very high level on our model is we are looking at the full continuum of wanting to make sure that those in community can stay there and want to stay and can stay healthy. So that's probably 70 to 30% of our work, where we're really focused on facilitating, making connections, and supporting those that might have higher needs so that they don't fall through the cracks. Some of those pieces can really be focused on clinics, health promotion, prevention, those types of care, and that's probably a majority of our work. But we do know that obviously as you get older, there may be more needs that you want. So we want to keep people healthy for as long as possible. But where there is a need to get healthy, maybe somebody has a health condition, maybe they don't want it to get worse, we do have a link into another arm of services where we are more formally connecting in with health and social care services that exist today. So that's the larger, what we call our kind of integrated health and social care model. And then if we could go to the next slide, I'll just give a little more detail. I think one of the pieces we were asked to share about is just what does our model look like and what kind of staffing is in there to support the buildings. And so what you'll see here is on the left-hand side, when I was speaking to the get healthy or stay healthy component, we've invested in identifying what we call NORC coordinators. And these are individuals that are on site in buildings, really start to help create a primary point of contact, create relationships and trust. But they're there so that they can look at recognizing and getting to know residents and see changes and decline over time. We've seen a significant impact in that, and that residents are, getting to know and really feeling safe enough to participate in more activities, disclosing more health concerns, some of the challenges they might be experiencing where they maybe haven't had someone to share with them before, or maybe they wanted somebody that was a bit more of a neutral party to be able to talk to. And the last area that they focus on is really what is that community building, the support that residents need, and help them to connect in and support those resources to be on site. And then on the right-hand side is really when somebody needs to get healthy. We do first and foremost linking with primary care wherever possible. But if there is a gap or maybe we can't get there quite quickly enough, we do have a team, a very, very small health team that is linked with an integrated care lead that really helps with coordination and navigation of services. And then if required, if there's really a health concern to be addressed, we do link in with a nurse practitioner within one of our clinics. And so that really helps us to complete the whole continuum. And maybe before I turn over to Jen, just to give a quick summary, we're currently in 23 buildings now, right across the city of Toronto. That represents about 4,000 older adults. And we are starting to see within our first 7 months, really quite an impact in terms of the trust relationship community that's being developed, as well as some impacts around accessibility to care, really navigating the system in a timely and appropriate way. So happy at another date to kind of share more of those details around what we're seeing as we mature. And I think I'll pass it over to Jen now.
Thanks, Melissa. Yeah, just to carry on, it's, these are pretty short presentations, but hoping to give you a sense of all the work we're doing. As Melissa mentioned, we're in 23 buildings, and we're currently piloting 2 models at various intensities. And part of the reason we're doing that is to really try to understand, there are NORC buildings across the city, co-ops, condos, apartments, ones that are located downtown, ones that are in the inner suburbs. And we're really trying to work with to try to trial our models in a variety of contexts so that we can understand differences in communities and local contexts, and what type and intensity of support they might require. So the slide that you're seeing right now is our staff model. And if we change now to the next slide, our second model is more of a resident-led mutual support model, which is called the ambassador model, and it's really the foundation of our work. You might say it's our first model, and then we've layered on the staff model on top of the ambassador program. And so the ambassador program is really focused on cultivating older adult leadership in the NORC community. It's focused on community building between residents and on participatory design with residents at each NORC location. Our coordinator works with residents in each building to form a NORC ambassadors group. Much like a traditional social committee, it's a resident-run group that's focused on supporting aging in place. So they are looking at building connections between residents to help residents feel connected, to stay involved, and to stay healthy. Next slide, please. We work together with resident partners and that ambassador group to understand both aging in place needs among residents in the building, but also preferences. And together, we started to bring in different types of programming based on each individual location. So it could be things like health talks and workshops, such as fraud prevention or managing your asthma, drop-in wellness classes, such as like exercise programs like chair tai chi that encourage healthy lifestyle, as well as social interaction between neighbors in the building, digital literacy training, social activities such as coffee chats. I just heard of a group the other day that was starting an informal investment chat group, group health clinics such as foot care, managing hearing loss, vaccinations. Really the heart of this in the ambassadors program model, as well as the staff model, is to look at, when you have a group of older adults, a population with similar needs, all co-located at the same address, how can we start to bring in services and programmings to meet the group's needs? So it's moving away from a one-to-one program service delivery model to a one-to-many. And, the system has done this previously with, say, supportive housing, but where this differs is that there are more buildings that house, 1, 2, 3, 400 older adults under the same roof, where we could look at doing similar things, working with older adults in the building, supporting their leadership and getting more resident-run activities going, as well as connecting them with services. Next slide, please. We've come to think of our role at UHN as the 4 C's. So the first one is, can we be a catalyst to help bring residents together who are interested in aging in place and building an aging in place community together? Can we help build their capacity to grow local leadership and to start an aging in place network? And then can we be a connector to connect them, build relationships with local health and social service providers who can help support to bring in programming into that NORC location? And then we provide ongoing coaching. Most of us are not born with learning how to do community development and building an aging in place network. So our coordinators are there and our team is there to help coach them to help continue this work with connection and capacity building. Next slide, please. You know, in terms of some of the impact that we've shown, we're still in early days, but I would say that, you know, some of the best impact is through the stories. And we were asked to share a little bit about how our program actually has impacted residents. And you can see a quote here from one of the residents that really talks about how the strength of our NORC program is that it's driven from the bottom up. And that it allows for the individual needs and ideas to emerge from the community. And then we are responding to that. But more practically, you know, on the mutual support side, you know, we've had one building that they've started. Residents have supported one another to bring folks who might be needing assistance with accessibility, getting down to group programming with a buddy system to bring someone down, to walk them down, escorts, which is pretty cool. You know, there are buddy systems just to support social isolation, but also to assuage some of the fears of dying alone and no one being there for them. So an example of that is there's a buddy system in one building where residents text each other and all they say every morning is just to say good morning. And they don't even need to necessarily respond. It's just to check in. But in one instance, a neighbor texted good morning and the person didn't respond. It turns out he was in the hospital. And because of this system, they had an agreement that if they didn't respond, then that buddy was able to contact their family to help make them aware of what was going on. And that's sort of the mutual support, that sense of, you know, there's somebody here, there's somebody listening, people you can count on to help support you being part of the community. And if that helps bring you into a talk on managing your asthma, which also helps with your condition, then that's wonderful. On the staff side and that connected care piece for the Get Healthy, there was a great example of a resident who had diabetes and was having trouble managing their diabetes that was referred into our integrated care lead and connected care hub to support the self-management that they were struggling with. And as a first step, there was a joint visit between the integrated care lead and the nurse practitioner to do a value-based assessment. And during this assessment, several needs were surfaced beyond their diabetes, including controlling or poorly controlled asthma. So this resident actually turns out they did not have access to primary care. So the nurse practitioner was able to actually connect with a local community health center to get them connected in and was able to provide access with a 3-month wait time. In the interim, that nurse practitioner was able to function as their most responsible physician to help the resident manage their condition in the meantime. So they were able to refer this resident into an endocrinologist to help manage their diabetes. They were able to do, because of the assessment the nurse practitioner did, the urgency was able to be conveyed to the endocrinologist, and they were able to schedule them in for a visit in only 3 weeks. The resident was also referred to an upcoming group session right in the building on managing asthma. That was also simultaneously translated into Mandarin, which the resident was. So that's just a little example of how our Connected Care Hub and Get Healthy piece works, and how the Stay Healthy, mutual support, resident-led programming works. I'm sure I'm going over time, but last slide, please. Just to say high level, what we're seeing as some of our early success factors is the participatory design approach, co-designing the program with local older adults. This helps ensure both right fit of the programming, but it also helps drive participation, sense of ownership, meaning and belonging. Our the holistic understanding of aging in place needs. So not just looking at clinical self-management of chronic conditions, but also looking at things like loneliness, sense of belonging, access to different types of services, navigation, coordination, support. Of course, the big focus on navigation and coordination has been really helpful, that connect piece. One of the things our team at the NORC Innovation Centre has done is to look at what are the resident needs across our NORC sites and to pre-arrange and look at service providers in the community who might be able and willing to deliver group programming on site. And so we have over 50 partnerships that we've built with different types of agencies who are available and ready to give group programming should residents request. And then the last piece is really a truly integrated care approach. And Melissa, my counterpart, is we switched the order today. She's usually doing this part, but she's really the integrated care expert here. You know, one of the success factors is that our Get Healthy, our on-site coordinators, and our Stay Healthy team, the ICLs and the nurse practitioner, all work together as one team. So there's not a wall between those. The site coordinator establishes trusted relationships. They're an ear to listen to for a resident to disclose something that might be bothering them before it becomes an emergency. And then they're able to connect in with the integrated care lead, share any pertinent information. Then they can take over, connect in with their primary care physician, arrange any type of services that might be required, and then circle back to the coordinator. So there is that sort of holistic one team approach that has been extremely beneficial, as well as creating partnerships. One of the big foundational principles of the UHN NORC program is that we are not looking to duplicate services that already exist. We're trying to work with what is working well in the system and to better connect and coordinate with groups of older adults who could benefit from their services. So key partnerships for us are the Toronto Community Paramedics, who have been doing handling rapid escalation for unscheduled events, but also doing some of those wellness and chronic condition clinics, so doing blood pressure clinics and that kind of thing. We're also working with Toronto Grace Hospital on a remote care monitoring program that can, you know, add another layer of support into what we're doing. So in many ways, our approach is, you know, how do we connect in with what's already working? How can we connect groups of older adults to things in the system? How do we build better communities of support? And I think that's our last slide. So thank you.
No, thank you. Thank you, Jen. Thank you, Melissa. That was an excellent informative, engaging discussion. Lots of questions are coming in the chat that I look forward to connecting you with at the end of the session. And something I really want to just highlight that I think is really going to resonate or is resonating with folks on the call is, you know, the active role of the residents in your program in both participating in the development and the implementation of the services and being folks who receive services. And that reciprocity, I think, is so key, not only to the sustainability of the program, but to that sense of health and well-being. I think that sense of purpose, that sense of value is really key to our health as we age. And, you know, it was once shared with me that, you know, people really assess that, you know, based on their answer to the question, you know, will I be missed if I'm not there? And I just get the sense that from your program, the way that folks are engaging, they have that sense they would be missed if they weren't there, that they're contributing to something for the community as a whole. And I think that the value that adds to health is tremendous. So congratulations. Thank you again for sharing and being willing to offer this information to our community. And I look forward to connecting with you again at the end of the session.
Thank you.
Can I invite Gloria to come on? Hi, Gloria.
Hello.
How are you?
Oh, great. Thank you.
Thank you. Thank you for representing our early bird population of the community today. I know you're joining from the West Coast.
Yes. Thank you so much. And thank you to Melissa and Jen. That was really fascinating. And I'm so excited to see how their projects develop over time. It's just really, really wonderful to read, to hear more about.
Yeah,
Cool.
absolutely. And we're really looking forward to hearing about Nav-CARE. Can I hand over to you now?
Absolutely. Thank
Uh,
you. All right, thanks everyone. I'm so pleased to be here. I am coming in from Vancouver, which is the traditional ancestral and unceded territories of the Coast Salish people, so that's the Musqueam, Tsleil-Waututh, and the Squamish nations. And I'm very grateful to be here and to be joining you all today. So I'll be talking about, next slide, please. Just giving a bit of an overview of what Nav-CARE is, how it was developed, some key ingredients to the not so secret sauce anymore, and share a few impact stories. So next slide, please. So Nav-CARE stands for Navigation, Connecting, Advocating, Resourcing, and Engaging. And it's a program where volunteer navigators work in collaboration with persons with declining health and their families to help them age in place in their homes or a home-like setting and to improve quality of life. And I'd just like to touch upon the words specially trained, mentored and trained volunteers. So volunteers are supported by volunteer coordinators who are located in particular organizations. And these coordinators are really important to facilitate the matching process of volunteers and clients and supporting volunteers as they develop relationships with clients and families, and then really connecting those volunteers together to create a community of practice. Next slide, please. And by trained, I mean that volunteers are provided with competency-based navigation education in these 5 areas with the purpose to negotiate the best fit between the needs of the person, the family, the community, and available resources, to improve access to needed services and resources, and to promote quality of life, foster independence, and facilitate community connections. Next slide, please. So the program is based on some key principles, and I'll just go over this briefly. First, central to it is about supporting quality of life through the building of social connections and fostering compassionate communities, to provide early support and journeying with persons living with declining health and their families along that illness trajectory. And to connect people to resources in the communities. Some things that we've learned from our research is that communities can have a real robust resources, and that many people might not know about this. And so connecting volunteers, knowing their communities really well, and then connecting clients to these resources has been very significant. And then finally, building volunteer capacity through that provision of competency-based training, and then supporting those volunteers through that volunteer coordinator mentorship. So next slide, please. This building capacity then with volunteers can support a variety of people and families with a variety of needs and a variety of contexts. So people who might be facing loss and declining health or experiencing complex decisions, and the kinds of treatments that, decisions that might be coming around with complex treatments. So next slide, please. So what do volunteers do? Volunteer job is to assist clients to navigate the changes and needs that arise as clients seek to live long and well within their homes. It is a long-term relationship of helping with 5 primary functions. That's first, to really develop relationships with people and get to know them really well, to help them with tasks that people might find challenging to navigate, to listen, to find resources and supports and communities that might benefit the person, to listen and well and deeply as people make transitions and decisions that arise out of declining health. And then finally, to provide a safety net for those living at home alone or without family nearby. So when they visit, volunteers are trained to ask, what is most important to you today? And this question helps them focus on any navigation activities, on quality of life concerns that an individual or family might have. And this is kind of different than what healthcare navigation is. which is more of a professional role that helps focus, help people navigate the complexities of the healthcare system. Next slide, please. So we're asked to talk about how our programs are developed, and as you can see from this timeline, it is have been in development for many years, and it's the years of collaborative efforts led by Dr. Barbara Pessett from the University of British Columbia in the Okanagan and Dr. Wendy Duggleby from the University of Alberta. And so looking at the development of the conceptual and theoretical foundation of the program, the development and refinement of curriculum, and then piloting the volunteer role and testing this. So it's really scaling out to build evidence. And so here we're at now in beyond 2020 in the scale up and sustain aspect of the program, and this is being supported by Health Canada. Next slide, please. And we're also in process of some new developments. First is a project led by Madison Huggins, a doctoral student who's looking at developing curriculum for volunteers to support families and individuals living with dementia. And there's another project led by the brilliant Kara Basil, who's looking at the feasibility and acceptability of the program in the context of an Indigenous context, and some exciting developments across the pond with our European partners. And there's a randomized pragmatic control trial of the program in 6 different countries, which include Portugal, Poland, Ireland, Italy, Netherlands, and Belgium, and looking specifically at supporting older adults living with cancer. So next slide, please. The program is typically implemented in hospice palliative care organizations, but over the last number of years, there's also been uptake in health authorities, municipalities, and other community-based not-for-profit organizations. And to implement, organizations have access to a Nav-CARE toolkit, which comprises of sort of an implementation manual, which helps organizations assess their readiness for implementing Nav-CARE, a suite of tools for a volunteer coordinator, which also includes evaluation resources and promotional and presentation materials, training materials, which includes online access to online training. And then organizations also participate in a community of practice where they can share their successes and challenges with others who are implementing and or have implemented the program. Next slide, please. So to date, we have implemented about 50 odd organizations across Canada. You can see we're pretty heavily represented in the West due to Wendy and Barb being located out here, but we're starting to grow into Eastern Canada as well. Excuse me. And since 2021, we have trained about 700 volunteers across the country. So it's very exciting to see this, this take up. So next slide, please. Excuse me. Sorry about that. So some of the secret sauce lies in these 4 quadrants, and I'm only going to briefly touch upon 4 aspects of this. And the first key significant piece of Nav-CARE is about the volunteers. And I hear over and over and over again from the volunteer coordinators how special their volunteers are. They are compassionate and loving and incredibly resourceful, and they're deeply connected to their communities. And in turn, then they can connect their clients and families to the communities in very significant ways. The second aspect is I get the privilege of leading that community of practice, and I'm so struck by the volunteer coordinators who are champions of the program in their communities. And I have such respect and awe for these community leaders who have a passion for fostering compassionate communities through supporting the well-being of the volunteers, the clients and families, as well as the communities. They are deeply connected to their communities and are really, really real champions of not just the Nav-CARE program, but just champions in of themselves. So the third aspect is Nav-CARE has been envisioned as a palliative approach. Sorry, can you go back to that slide? Thanks. So Nav-CARE has been envisioned as a palliative approach to care, collaborating and working with individuals and families early on a person's journey with illness. But as you can imagine, the language of hospice, palliative, death and dying can engender a lot of fear and discomfort. And so one of the significant learnings that we've found is that there needs to be careful framing of the program and framing the program in terms of meeting where the clients and families might be at in their journeys and what they're ready to hear. And so that's been really important. And then finally, as the program is implemented, and Jen and Melissa have touched upon this as well, is to think about the overlaps in different programming and overlaps in the types of populations that is served. And so rather than thinking in terms of competitions and really rallying for different, for volunteers and so forth, it's about how programs can work in collaboration and partnership with each other. And this is again where the volunteer coordinator is such a champion, as they really make a difference in fostering relationships and collaborations with other programs and partners. Next slide, please. So in terms of impact, this is a bit of a summary of studies, and you can read more about the research. You can find articles on our website. So really in particular with clients, they've shared about the tangible benefits that really improve their illness experience and how volunteers have really made important contributions to their quality of life. Volunteers have talked about how important it is to them to develop meaningful relationships and making an impact in individual and families' lives, as well as making an impact in their communities. And they really have talked about how they can give. This is a way that they can give back to their communities. And the organizations that we've partnered with have really talked about how Nav-CARE is meeting an important need within their communities. And so that's really great to hear. So next slide, please. I just want to share a few quotes from some of the Nav-CARE participants and how they have viewed the program and the impacts that it has made for them. So in this quote, we see a participant talking about her connection to the volunteer and likening this connection to a friendship. And these volunteers really have that time to take that time to develop these relationships with participants, and so that it develops into a friendship is not surprising. Next slide, please. In terms of advocating, we can see from this quote that the participant expresses that having a volunteer advocate for her is really important, because she was asking a friend to do that, but that was putting a lot of burden on her friend. So having a volunteer to step into that role was really important for her. Next slide, please. Here's a quote from a participant that illustrates how volunteers connect them to communities and to different programs in their communities, and also to resources that the participants and clients might not necessarily know exist. Next slide, please. And finally, here's a quote about a volunteer helping a client engage in activities that are important to her. So getting the client to appointments and getting the client involved in different exercise programs. So you can read more about volunteer stories and client stories on our website again. And next slide, please. And this is where you can find us at navcare.ca. And if you'd like to learn more about the EU project, please go to the eunavigate.com website. Thank you very much. I'm really looking forward to our time for questions. Thank you.
No, thank you so much, Gloria. That was wonderful, and I can guarantee that there will be a lot of traffic on its way to your website today, just based on the what I'm seeing in the chat. You know, nice mix of both questions, but also just reflections and compliments. You can tell that this is really resonating, and I think what drew us to this program when we first encountered it was that the program is based on relationships. Like that is what creates the value of the program, is that it's all deeply connected to the relationships that are formed, and even more so than the specific health and care services. And I just love that about this program. So at this time, I'd love to invite Jen and Melissa back on screen. We can hopefully connect all of you with these excellent questions. Welcome back. Feel free to come off mute. Hard to decide what order to go in here because there's so many great ones. But maybe I will give you a little breath, Gloria, having just presented, and maybe connect Melissa and Jen with the first question. And we received a number of questions around you know, the potential for NORCs in rural communities, and how a NORC could potentially work in a rural as opposed to an urban setting where maybe it's not so much of a vertical building type of implementation, and just your reflections on that.
Mm-hmm. Yeah, no, happy to take that one. We get asked this all the time, and I would just say that for us, we've started with vertical communities really based on that census data that shows this increasing trend towards older adults living in high-rise buildings. In being in Toronto, that was sort of a natural place for us to start, but that absolutely there is a lot of opportunity to look at neighborhood NORCs, which could be groups of buildings or just a defined area, as well as rural. And so we're just in our early stages right now of actually trying to look at transposing our program model into a neighborhood context. That would still be in Toronto, but would actually be very helpful for understanding some of the considerations in terms of program space, in terms of governance, in terms of communication, that would need to be worked out to apply the NORC program model to more of a diffused and dispersed community. So we are hoping to work on that in the future, but just with our limited capacity, we're sort of focused right now on vertical individual buildings.
Thanks.
I could try to answer that more clearly and just saying that, some of the big considerations are, of course, you're going to have group programming, they need to have space. And so how do you do that? And there's, examples from different communities of looking at businesses donating space, looking at places that are traditional third places like public libraries. I know that the Ministry of Seniors and Accessibility have active living centers that they're trying to make more use of. So those are good partners if they exist in your community, as well as sort of thinking about governance and really how do you create a participatory model amongst different communities? How do you ensure that people who are maybe more isolated are brought into the conversation? And I think a lot of it's really about training people who are really residents, volunteers, to think widely about compassionate listening, about sharing decision making, about some of the skills involved in sort of being more relational and community minded.
Thanks, Jen. Lots of considerations that, I think there's a lot of overlap. There's a lot we can learn from our vertical NORCs that will help us establish more effective horizontal community NORCs. And I think, like you said, there is a lot of interest in this, and we hear about this often as well. So hopefully something that we can bring to this audience in the future.
Absolutely.
Yeah. And I did notice that some folks are are wanting to participate in the conversation using the hand raise feature. And my request would be if you're able to put your question over into the chat, then we can put it into our sort of production system in the background and have an easier way of connecting it with our folks either here real time or after the event when we ask our speakers to respond to all the questions that were asked, including the ones we didn't get to today. Gloria, I'd love to bring you in to the conversation. There was a reflection in the chat that I'd like to sort of frame as a question. And it has to do with the relative merits of having NavCare volunteers versus hired system navigators. And, you know, is this really about a money issue? And is that where the value is coming from? Or is there certain benefits to having that come from the volunteer sector? And just would love your thoughts on those two models.
Definitely. Thank you. That's a really great question, and definitely something that I also grapple with. And so yes, there are definitely like paid navigation models out there, specifically around healthcare navigation. So helping persons sort of navigate those complexities of a healthcare system and connecting people to different resources in through the healthcare system. And I think the difference, and you touched upon this when you kind of gave that little summary statement there, Andrea, about, I think the difference is where volunteers actually have the gift of time to develop that relationship over a long period of time. And so I don't think our systems necessarily support that kind of gift of time, and that flexibility within that as well. And so to develop those relationships, so it's not an in and out thing. It is not a client is, you know, finished with the system, they are now no longer on a service. That volunteer can be there over at that long period of time, over that illness trajectory. So I think that's where that key difference is, and where a volunteer is really important. That might not be what a healthcare provider potentially could offer like that. So that's what I would say.
Thanks. I can really feel in your response, you know, the beautiful stories that you've witnessed as you know, at the hands of volunteers, having that extended time that's really needed to develop the relationship. Do you think
Yeah,
there are limitations to what the volunteers can support relative to what the needs are?
absolutely. Absolutely. So, you know, there's a lot of folks who have complex needs, and that go beyond the boundary of what a volunteer can offer or should offer. And so, like, I think about some, as we, you know, we know that our health system is really challenged right now. And so volunteers are being asked to step into these roles that are not necessarily, that they shouldn't really actually be stepping into. So let's say a volunteer has some healthcare background, and people know that. And so, and that's not the hat that they're wearing right now. So, and yeah, so I think there are boundaries around what the volunteer can do and what we can ask them to do, because they are volunteers. They're not being compensated for their work in significant ways, like in monetarily wise. So yeah.
Yeah. Well, and because this connects to what you were just saying, I wonder if I can add a tag on question, which is, you know, whether there are embedded, like whether this program has been coordinated with access and navigation mechanisms. So are the formal
Yes.
and volunteer sectors in some way collaborating around the navigation issue? And
Absolutely, and this is where the volunteer coordinator is just such an integral piece of this puzzle, in that the coordinator can work closely with, like, let's say case managers, or others in the healthcare system and sort of be that conduit between the health system and the volunteers. And so case management could refer to the volunteer coordinator, say, hey, I think this client could use a little bit extra support. Is there a volunteer who would be willing to step into this situation? And so we do have some partnerships with different health centers or health authorities that are sort of integral in making those referrals and making those connections with the volunteers.
Thank you. That's helpful. And Melissa, I was actually going to just bring you in on a similar question in a similar vein. So please go ahead.
Well, I was just going to say, Gloria, amazing work. And Jen and I were trading messages, like, how could we better connect maybe with Nav-CARE kind of in the work that we do? I love the question. I think there's a role for both, and maybe just some considerations for those that are listening in. But there is quite a lot of work, and I'm sure you've run into this, Gloria. Like, the longer term developing of relationships also comes with like an emotional weight. I think of the kinds of conversations that individuals are having. So that training and preparation and support network is really critical to think about as you're thinking about these kinds of individuals and the conversations, the environments they're being put into that we've started to see with some of our coordinators. So there may be some way to look at that, is what is the intensity of that. And then we've already touched on it. It's different level of coordination, but some of the value in the kind of with the systems or services that are in place does require a dedicated resource and likely some expertise. Because really the beauty of these aging in place models is that you're doing something quite soon, as early as possible in that, your health and well-being as possible, so that you can avoid anyone getting sick, or if there's early indications, you can kind of circumvent that. And so I think it's really important in these models that you have that really timely way to do that. I don't know, Gloria, you may have ideas on it, but how do you do that kind of with the volunteer base and some of that expertise that you might really need to quickly navigate and access services quite quickly?
Thanks for those reflections, Melissa. Maybe Gloria, if you wanted to comment, and then I'll invite Jen if you had any final thoughts before we wrap the end of the webinar.
That's okay. I think I spoke enough.
No, we appreciate all your contributions. Jen, did you have any reflections on this and the sort of system model between, volunteer and resident contributions and formal health system? And
Yeah, I mean, maybe the last thing I would add is one thing we talk a lot about with our ambassador groups, that the language they came up with, you want to, there's a tension between creating a sense of community, an aging in place community, and what are the boundaries around that, especially when you're co-located, in the same address or in the same community. And the way they put it, they said, we're here to look out for one another, not to look after one another. And I really like that language a lot. And so there's some boundaries there around how do you do that well? And there's coaching that we try to do around, what does helping mean? And so I really think that framing is important. I think there's a reality in our healthcare system with, the number of older adults that are, coming into older age as this next generation of the boomers. That just sounds so aggressive, but there's obviously a massive a generation peak coming, and we already have issues with enough healthcare human labor being in the market and available. And obviously those are things we need to work on. But I think there are reasons to work with older adults as partners, and that's to ensure the right fit of programming, that we are working in partnership to shift that as needs change over time. But that it's also, there is a lot that communities can do to support aging in place that are little things that really fall outside our public system. So, a lot of people can stay at home and they can cook for themselves, but they can't open the jar anymore, right? Or it's like, I need help with snow shoveling, or, picking something up from the grocery store, or, just someone to listen to sometimes. So I don't think when we're talking about aging in place, there's a lot that falls into that realm. And that if we can do a better job of coordinating the system and then connecting in, how do you create a connection between those two pieces, the voluntary and the formal system?
Well said. Thank you. Thank you for ending us on such a beautiful thought. How can we continue, um, to look out for one another? And that's what this is all about. So thank you all for your excellent presentations. There's a poll that's just popped up on your screen. If you could just take 30 seconds or less to submit your answers to that, we would really appreciate it. We look forward to seeing you next month and our final Promising Practices webinar, April 25th at same time, 12 p.m. Eastern. Again, thanks to our wonderful speakers. Thanks for sharing all of your energy, your hard work, and the impact that you're having to enable aging in place in Canada. Stay well, everyone. Stay connected. Thanks so much.